Good afternoon, everyone. Thank you for joining early. We'll be kicking off in a minute or two. While you're joining, it would be great if you didn't mind popping your name and where you're from in the chat if you're happy to share. We're keen to hear who's online and get a sense of people who have come to listen and learn and share. So please do start introducing yourselves into the chat. I'll include my lovely panelists. Panel members within that too. So let's get introducing ourselves while we wait for everyone to join. Great to see lots of people trickling in. We'll give it another minute or so and then we'll get started. If you've just joined, please do come and say hello in the chat and introduce yourself. It's great to see you on. Okay, I'm gonna kick off with a gentle start and say a welcome and hello. Thanks to everyone who's joining. I know we'll probably see a few people trickling in over the next few minutes. We've got a fantastic hour ahead of us with you all, and so delighted to see that you're on the call and here to listen and learn about the mission approach that we've taken to innovation in North West London. And I will have the panelists introduce themselves as they come in and speak, but we are going to be having a fantastic hour of which we're very keen to make sure that we allow enough time for questions, comments, reflections, feedback. I'm very keen that we use the chat in an active way. So please do start introducing yourself in the chat if you're happy to do that, and start to store up, pop questions in, any comments, reflections, observations as we go, and we'll try and pick up as many of those as we can. So let's kick off. We're just at 1:02. So thank you for joining. The session today is about a big question that many of us are grappling with across health and care systems. And we're really focused on why does innovation so often succeed in pilots but fail to change in our wider systems? And that's really the focus of the work that we've been doing around our mission-led approach. So just over 2 years ago, North West London made a really deliberate decision to change how we approached innovation, not by launching another programme, but adopting a mission-led approach and aligning partners around a small number of shared priorities over a longer time horizon, with the explicit intent of trying to really deliver system-level change. And so this is really the basis for what we're going to be talking about for the next hour. My name's Dominique Allwood and I'm Chief Executive of Imperial College Health Innovation Partners. And we are a health innovation network for North West London. And I'm going to just tell you a little bit about us and how we've been sort of supporting and leading some of the work. So next slide, please. For those just joining, do say hello in the chat and use the chat for question and answers. That would be great to see you. I wanted to just let you know, if you're not familiar with HINs, Health Innovation Networks are the organisations that help accelerate the adoption of new technologies and best practice to improve patient outcomes, to boost economic growth, and to really tackle those challenges around sustainable health and care systems. And we are one of those partners based in North West London, covering at the moment until April a population of 2.8 million, but soon to be expanded across a wider ICB geography. And we have a really diverse population and some brilliant assets around innovation and research, including world-class institutions and lots of data and brilliant delivery organisations. But I think it's fair to say that we haven't always managed to organise ourselves well to get innovation scaled and spread in the way that really starts to have big impact. So this is about our partnership there. You can see all of our members on the slide there. And really, this was about saying together we're a collective set of organisations that want to improve health and care for people through innovation. How do we do that in a different way? So what we're going to be talking about is what we've done to shift that in practice using our mission-based approach, and taking a chance to do things for longer with more focus, really thinking about how to get innovation spread and adopted in ways that make a difference to populations. And so this is more than just about a report. This is about really sharing warts and all our learning around system and mission-led working. Next slide, please. So a couple of bits on the agenda that I'm going to tell you about. We're going to talk a bit about what it means to be mission-led. You hear that buzzword all around the place, mission this, mission that. We're going to talk a bit about how we've been doing that. As I said, this is a learning session, so we're really sharing in honesty what has happened, what's worked well and what hasn't, with a real focus on method and approaches and leadership. We're also going to bring in a real world example to show you how one of our first missions was really set up and delivered, to give you some practical examples so that it sort of goes beyond just frameworks and slides. And we're going to hear from some of our system leaders who have been part of that about what has really been happening on the ground. We want, as I say, to make this really interactive and make sure that we encourage time for sharing, learning and questions. So whilst we're going to talk for about just over half the time, there's so much we could say. We could run for hours, if not days, with all the things that we've done, the details about how do you really set these things up and deliver for success. But we're keeping ourselves in check. We're going to make sure that we allow plenty of time and interaction for those questions. So do pop them in the chat as they come to mind, and we will make sure we get to as many as we can. So hopefully we're going to give you some insights and leave you inspired, with a sense of realism about what we've been able to achieve and what you might be able to as well. And great to see so many people in the chat coming from a huge range of different places, including providers, industry, and supporting organisations. I'm going to hand over first of all to our speaker, Matthew Chisambi, who's going to give some more details on what a mission-led approach is and why we decided to start working in that way. So Matthew, over to you.
Thanks so much, Dom, and good afternoon, and appreciate everyone who's taken the time out to join us today. So I'm Matthew Chisambi. I'm a director at Imperial College Health Partners, and I've actually been part of the North West London system for coming up to a decade. And as Dom outlined, we are very fortunate, like other parts of the country, where we have these individual institutions that are national experts or world leading in sometimes. And therefore, this question for us, which really led us down this mission approach, is how can we get those different actors to work coherently towards some really key goals? And that is the fundamental kind of aim of a mission-led approach. So next slide, please. So we're at a really difficult time for health and care services at the moment. So the NHS, public satisfaction with the NHS is at an all-time low, and therefore we really, as system leaders, need to think about what it is within our gift to try and actually address some of the fundamental challenges that residents and patients face. And with that was the kind of burning platform for us to consider moving to a missions-based approach and think about how we can make sure that we can scale innovation in an equitable way, because we know that there are lots of innovations which are available right now, but they are not distributed effectively across our population. Next slide, please. And that's what led us to a mission-led approach. So in terms of missions, we have borrowed very heavily from the work which is led by Mariana Mazzucato, and really thinking quite intentionally about how we really unlock the collective efforts from different actors through focusing on fewer priorities for a longer duration and with this impact-driven goal within that. And what we have sought to do is set missions which are really collaborative efforts across disciplines, across organizations, and across sectors. And it's only by selecting problems that really generate that kind of cross-sectoral challenge that we can really kind of make deeper impact on some of these really intractable problems which we face in health and care. Next slide, please. So within that, there is a growing evidence base for the adoptions of missions, and reflecting our own organizational story. During the pandemic, we in effect closed down and really lent into the North West London response. And that was such a period extremely challenging, but we saw certain innovations really leapfrog progress, which has been mooted for 5 to 10 years within the period of a year or two. Services transitioned from being purely face to face to online. And a key kind of reflection of that was this focus. We all had this very, very clear goal, which morphed and changed over the duration of the pandemic, but it created, I suppose, a huge innovation dividend within that. And therefore, what we're trying to do with missions is create this very singular outcome focus, which both demand signals to parties outside of our health and care system about what is important to us. And then we pool in resource to try and make tangible progress within a set time period against those goals. And that fundamental kind of work is really important. But as Dom said, we want this to be an open fact conversation. We probably underestimated internally what that meant for us as an organization. We had previously had priorities and programs and so on and so forth, but switching to having three things which really drove all of our operations, created this discretionary headspace, was quite a significant jump for us as an organization. And that led to lots of learning, which is more detailed in the report. Next slide, please. So we set out, and in terms of learning, they definitely weren't missions at the start of this, but we set out with three broad theme areas within that. And so our first mission was about optimizing the care of long-term conditions, starting with cardiovascular disease. The second was around enabling more days at home, starting with the acute pathway. And the third was around supporting children and young people's mental health. So with these broad areas that emerged out of the pandemic, we had to do quite a lot of work to be more adherent to the methodology and create tangible impact statements. And therefore, what you can see at the bottom of these is where we kind of evolved to those. And we also had this fourth mission, which is around this enabling capability. So what's required to be successful in a mission. And I think for me, that's been the biggest kind of learning dividend within this. Actually, by creating focus on fewer areas, what we've been able to do is really learn about what some of the underlying structures and challenges are across those theme areas. And we've been able to put a I suppose, a discretionary effort into thinking about some of those key enablers, whether that's evaluation, whether that's data, whether that's funding. And that's been a massive unexpected mission dividend for us. Next slide, please. So reflecting on the 3 years that we've had, I think the key kind of pillars of our reflections are clear mission goals. We spent far too long in a discovery phase because we weren't really clear on what impact we wanted to have within a mission. I think this is our clearest kind of learning point, which we're applying to our new mission area of obesity, where we're going to spend quite a lot of time of trying to work out what the tangible mission goal is before embarking on that next step. Then second is we created this concept of living labs and innovation networks. So what we really wanted to do is create these living labs, which were comprised of industry partners, a tangible system problem, and real world evidence, both qualitative and quantitative. And then we sought to scale those through innovation networks. I think in retrospect, one of the learnings around this is that we probably spent too long trying to identify test sites within our patch, and actually agreeing where we would test and securing commitment from all parties to have those test sites up front is probably something that would save us a lot of time in what we're trying to do in our new mission. Then iteration. So some of the missions have been in really lack of progress places. And we've had to make quite intentional and difficult pivots of where we focus our activity. One of the biggest kind of tangible aspects around this is in our children and young people's mental health mission, where due to lack of data infrastructure and also the levers to scale some of the work we were doing in neighborhood health, we've pivoted to a tangible kind of referral management system where we're still able to have like the composites of a living lab, but that also starts to create a platform for much more actors to start to join. Then in terms of innovation and implementation science, we've had to really think about what our approach is to innovation adoption. And I think the key kind of thing here is tailoring the right type of approach for the problem or initiative that you're trying to do. And then penultimately creating this learning health system. So how we actually kind of think about the key kind of impact measures that drive some of our decisions. And this last one, I think for me is perhaps one of the most important, which is how we actually create some of the ongoing incentives to design to transition any emission initiative into business as usual, rather than getting to the end of a pilot, not having funding, which is all road that we've touched before. And that is some work which we're really looking at in earnest now, and we're starting to see some scale. So, for example, within our first mission in cardiorenal metabolic disease, we're scaling a particular initiative to 300,000 patients, having worked with an industry partner to secure some investment. So we're starting to see some signs of this approach. So with that, next slide, please. So Adam is going to talk through Optica, which is a product on the federated data platform, and an example of our work within our enabling more days at home mission. Over to you, Adam.
Thanks, Matthew. Good afternoon, everybody. I'm Adam Ashworth. I'm Innovation Lead and Mission Lead at Imperial College Health Partners, and I led our mission to enable more days at home, which Matthew mentioned before. The focus for this mission to enable more days at home was to address challenges in patient flow, with the goal by 2026 for the North West London health and care system to enable 50,000 residents to spend 180,000 more days at home with the right support for them and their families. And what I'm going to do is zoom in on one of the initiatives delivered under this mission, which was the Optica work that we delivered. Next slide, please. So first of all, to comment on the problem, no one wants themselves or a loved one to be in hospital when they don't need to be. And optimizing discharge was one of the key focus areas for our mission to enable more days at home. However, safe, timely discharge from hospital is one of the most persistent challenges across the NHS. In April 2023, 14% of the beds in North West London were occupied by patients whose discharges were delayed, which was at the time the highest proportion in London. Every delayed discharge impacts patients, staff, and the wider health and care system. It creates inefficiencies, strains capacity, and affects the experience of those who are in our care. This is one of the most complex problems affecting the NHS in our region and nationally. The process for safe and timely discharge of a patient from hospital requires multiple members of staff across different disciplines with different expertise to be involved, sometimes across different sites and organisations. In North West London, the region had implemented tools to support discharge coordination, but these were not being implemented consistently across the sector. Our optimising discharge workstream was focused on testing and iterating innovations that support safe and efficient discharge of patients. Any technological solution or innovation had to allow for collaboration across teams in multiple settings, focus on patient need, and provide an improved pathway. So what was the innovation that we focused on? So as the region's innovation partner, we work closely with clinicians, system leaders, charities, patients, and industry partners to ensure that we tested and implemented the right solutions in the right settings. Optica, the optimized patient tracking and intelligent choices application, was selected as a solution to prioritize. Optica is a secure cloud-based application designed to provide NHS and local authority teams with a shared real-time view of patients approaching discharge. It's one of the products available through the NHS Federated Data Platform and supports NHSE's strategy for securely connecting data, breaking down silos, and providing actionable insights to improve decision making, reduce costs, and enhance patient outcomes through use of the National Data Platform. We formally tested Optica at 2 North West London sites across Trust and local authority teams. Hillingdon Hospital, working with Hillingdon Local Authority, and Chelsea and Westminster Hospital, working with the Royal Borough of Kensington and Chelsea. The goal was to streamline coordination, reduce delays, and ensure patients receive the right care in the right setting at the right time. To support implementation and adoption, ICHP delivered a comprehensive support and training programme for local authority and integrated discharge hub staff from June to August 2024. This was to ensure that ICHP equipped staff across the implementation sites with the knowledge and skills needed to effectively use the programme. This support programme included a diverse range of training formats and accessible resources, including one-on-one training and team training sessions, user guides, reference sheets, scenario-based examples, development of SOPs, quality improvement, and more. Following implementation at these 2 test sites, ICHP conducted an independent and rigorous evaluation of both the implementation and impact of Optica. So what of the impact? So the headline results from Hillingdon hospitals included a 23% reduction in unnecessary bed days, improving patient flow and freeing up hospital capacity, nearly 1,000 staff hours saved, reducing administrative burden and enabling more time for direct patient care, approximately £62,500 in estimated annual cost savings from improved efficiency and reduced administration burden, with additional savings potential from improved length of stay and workflow enhancements. The quality of evaluation also showed improved staff confidence and collaboration, with teams reporting better visibility and coordination across organisations. So what difference did taking a mission-based approach have compared to running as a normal innovation project in this case? So there are 4 key points for me on this one. First of all, taking a mission-based approach effectively created a movement that aligned partners and secured their commitment. Secondly, it provided clear intentions to evaluate. We knew a robust evaluation would be carried out. It wasn't just about implementation. Thirdly, it provided clear intention to scale, which grounded the work at each site, for example, the development of consistent SOPs, into the bigger picture of scaling. And finally, these mission intentions were embedded clearly and transparently in the mission governance that we'd established with the support of our Research and Innovation Board across North West London. I'm now leading our new obesity research and innovation mission, and there are several learnings to take forward from our work that are reflected in the report that was launched this week. And I was discussing these with our Research and Innovation Board this morning. So the 3 key ones for me are the championing of shared ownership through the R&I board, really reducing the risk of the work that we're doing being perceived as solely a health innovation network and ICB projects. Secondly, the commitment to scaling is really important from the outset, and get that embedded in the responsibilities of the board members that you have supporting the initiative. And finally, to better enable data access, as many delays were caused by barriers to data access for us. What are the next steps for this? So Optica offers a significant opportunity to improve discharge planning and coordination across health and social care in North West London. Our ICB are working with a consultancy partner, PSC, to scale this approach across all acute sites and local authorities in North West London. And if the improvements seen at Hillingdon are replicated, this will enable around 22,500 more days at home for our residents. As part of our evaluation and drawing on best practice in digital transformation and system integration, we've developed a set of recommendations which outline how Optica can be embedded, scaled and sustained to deliver meaningful impact for patients, professionals and providers, which we can share with this group and is available on our website. And I'll drop the link to that in the chat. Dom, I think I'm back over to you, unless there's any particular questions that came up in the chat that you want me to answer.
We'll come to you, Adam, when we pick up all the questions that are coming in. We've got a couple already, so if anyone's got questions, do pop them in the chat. Thank you. In a moment, I'm going to do a little fireside chat with Charlotte. We don't have fire. I do have sunshine in South London, but no fire. But before I do that, a few people trickled in late. So just a bit of a recap. We're talking about our report that hopefully you've all had a chance to have a look at. We have hopefully shared some of the big sort of picture things that we've tried to do with this mission-based approach. So picking places or spaces where it's a big goal with something as a problem that can't be solved by one organisation or one team alone, and doing fewer things for longer. And what we've done is share some of our overall methodology, and I've put a few links in the chat where you can look a bit more about some of the different steps we've taken around selecting our priorities, discovering, delivering and scaling. And then Adam has just given us a little deep dive into one of the missions that we chose. It's like choosing favourite children, but we had to pick one to showcase. But there's lots of other work going on in the space of cardio-renal metabolic and children and adolescent mental health. So we're going to zoom out a little bit now, and some of this work takes quite a lot of change in the system and changes in the way in which we lead and govern our work, given that we're working across organisations, across teams, sometimes across sectors. So it's a pleasure to welcome Charlotte. Charlotte, why don't you introduce yourself, and then I've got a few questions for you and I to have a chat over.
Thanks, Dom. So good afternoon, everyone. Really thrilled to be here with you all. So I'm Charlotte Benjamin. So I am currently the medical director in London region for cardiovascular prevention and chairing the London Clinical Senate. And really, I'm talking today in my role where I've been the chief medical officer across North West London. And I must say, one of the most enjoyable elements of the role was, as Dominique has just said, that system leadership to see how do we align around supporting innovation across the whole end-to-end pathway, ultimately to scale for the problems in the system.
Brilliant, Charlotte. I'm going to ask if we can take down your picture slide so we can have us spotlighted if that's possible, and we can do a little on-screen chat. So you know, it does take a different approach to thinking about trying to do things, a smaller number of things for a longer period of time. And so I'm wondering, Charlotte, what was some of the difference that you could like feel and talk about compared to previous innovation initiatives we've been involved in? And I'm sure no shortage of pilot work that you have had to stand up and stand down and not scale before. So what sort of felt different about some of this approach?
Thanks, Dom. So I think really it was a sense from the beginning of learning from where we'd had challenges. So we had, previously we've had a system where we had organisations each with their challenges with a sort of request list for support around innovation. But actually the learning that we did and the silver lining from the challenge of COVID in terms of all working to a singular mission really drove this forward in a really different way. So actually looking at seeing what are the system problems that we can't sort out organisation by itself or a small area by itself, you actually need the whole system to come together, and where you need a really different approach, because the challenges in the system are, you need to get buy-in for them, but they're in a way fairly obvious. But I think the more difficult thing is how do you stop siloed working that we all used to doing in organisations, whether it's as commissioners or at regional level or whether it's national or moving it to individual providers. How do we stop that siloed work to enable system working to bring us together? So I felt from the outset this felt very different, and I think the fact that we were fortunate to have created a research and innovation board across the system, across North West London, gave a really strong support and governance to and structure to actually sort of hold us to account for this missions-led approach. Then from a leadership perspective, the ICS, not just ICB, but Integrated Care System leadership, had regular updates on this. So actually focus was on these three mission areas and actually how are we going to progress through to enable us to get that evidence base, to enable us to move through the different processes along the mission, to enable us to get the evidence base to scale. So I think everybody was committed and everybody from the outset's quite excited about it. But I think like most things in life, people divert to sort of common ways of working that you're used to, and actually saying, no, let's not go into just our siloed problems. That was a sort of ongoing challenge that we needed to do. Plus, we had system challenges. So at the timing of going through majority of the mission work, we were having sort of regular episodes of industrial action. We had the winter pressures, and there's certainly no shortage for anyone in the system with an acute challenge to say, actually, I haven't got the time to focus on this. And the fact that we'd all signed up to the mission approach was say, no, step back. Actually, yes, of course, you have to as well address the problems on the table, but we have to create the space. And I think this approach did that. It created the space in the system to say, you're allowed to, and we're all mandating ourselves to actually commit to actually being able to help solve these problems, large system problems.
Brilliant. Now, one of the things that we talk about a lot in health and care is these time horizons, and we're often measuring money and impact in 12-month periods. I wish it was 12 years, 12-month periods, which is obviously quite strange when we're trying to make sure that we're measuring population health impact. So how do we help in a system understand what we can measure as quick wins that are sort of helping to secure more short-term funding versus some of these longer-term things? If we look back at the things that we've chosen, moving the needle on heart attacks and strokes, on neurodevelopmental pathways, waiting lists, outcomes for patients, these things don't just happen in a few months, particularly when we're trying to lay the groundwork for this work, which takes a lot of preparation. So tell us a bit more and some of your role in the advocacy around that, around how do we actually take a mission-led approach when funding cycles are usually quite short and tight.
Thank you. So I think as one of the key members of an executive team sitting on business case review group, it was ensuring that we've got that sort of that golden thread passing through. So actually, we need to do the background work to ensure that we've got the right evidence base, we've got the right testing, we've got the right evaluation, we've got the right evidence that we're bringing to the request for more funding. And the request for funding in a system normally comes through a business case review group. And I think what we did was actually feed in how the missions were working, and actually away from that need to do looking at multi-year projects. And I think that was quite a big hurdle to get over. And I think one of the things Matthew said in his was the enablement of having only 3 missions to focus on. You're able to focus some of that underlying enabling functions that would enable us to actually have the evidence base for scale. And so an online evaluation tool being one of the key sort of examples of that, how we systematize how we're doing evaluation. So actually we know the system knows actually what are we looking for, actually, what is going to enable us to make those decisions, and being really clear about that with all system partners so that actually you can understand what the ask is, because historically it's a very fragmented ask, all well intended, driven by needs, driven by organisations looking to actually look to see how do they shift the dial on a particular level. But actually all these issues that we have, those 3 system approaches, are not possible to do one organisation by itself. And it's that collaborative working with a fixed with a fixed process that we have encouraged has enabled us to do that. And indeed the Optica example that Adam gave, fantastic that we actually seen the input, seen some of those results to enable us then to say we're at a point in time that's not carrying on indefinitely. We're looking to actually embedding a new mission, and we've chosen as a system to be obesity. So it's trying to embed that governance, trying to embed that structure to help actually transparency, the whole system to know what we're doing together to actually enable us to embed that approach.
Brilliant, Charlotte. Thank you. Listen, we could talk for hours, but we're going to get on to some questions shortly. So thanks very much. And I'm going to bring you back in because there's a few bits that popped up in the chat that I'm sure you'll have a chance to answer. But thank you so much for your leadership. Right, I'm going to just do a last couple of quick slides on the learning, and then we will definitely open up to the chat. The chat is alive and buzzing, and exactly how I hoped it would be. People are introducing themselves. We're going to absolutely take credit for any matchmaking that has gone on. People are exchanging email addresses. There'll be WhatsApps in there. If there's a wedding out of this, I'll be delighted. So moving on, I'm going to just do a few reflections, lessons and considerations that we have been thinking about to sort of wrap up this last bit of our sort of talking at you. So I guess it's important to keep emphasizing, whilst we have been at this for at least 2 years, we still feel very early in our journey. And what we are trying to focus on is what it's taken to get to this point. And of course, the impact stuff is really important. But I guess what we're trying to do is share honestly where we've got to and how others might be able to shortcut some of their journey and learning if they're keen to take this on. And I'm sure Charlotte and others will have recommendations for those who are working more in systems roles about how you sort of do that and steward it through. But I guess we've seen some really important signals as to how the system is operating and changing. And you've heard a bit of that real world impact from Adam, but we're starting to see not just progress on the individual initiatives, but a shift in how the system sort of really behaves. And missions have added that anchor, that way of sort of maintaining a shared direction and trying to block out some of the noise about trying to be short-termism and say, no, we've agreed to commit to this and we're going to stick to these fewer things for longer. And in a context where priorities and operational demands change constantly, we've had to flex our tactics, but we've stayed true to the fact that we've picked priorities and stuck with them. One of the most noticeable changes has been in how partners work together. And we've gone from, I guess, systems that in the past have just potentially been quite competitive to more coordinated to something that feels more collective in the way that people are owning these problems and owning the solutions together. And we have involved a huge amount of different stakeholders in this work. And there's a question about VCS, which we'll get to, but people feeling more meaningfully involved in shaping the decisions, not just responding to them. And I think that thread around culture has come through in what you've heard, but I guess to be really explicit, culture feels like it is shifting and changing, and teams have become more comfortable with uncertainty. And I guess that appetite around some of the things around risk, like if we haven't managed to scale as quickly as we wanted to, or an intervention isn't giving the results that we want to, how do we learn from failure and pivot really fast? And we have been creating the environment to try and do that sort of testing and continuous adjustment, which I think feels different to often the places that we find ourselves. And these shifts are quite subtle, but they are really foundational if you want your innovation over the long term to translate into real system change. And so whilst the work is still early, we are seeing tangible outcomes. And what they really do, I think, is demonstrate that we can have this way of working that does start to move the dial on entrenched, big, intractable problems, complex ones that can't be solved by one organisation or one team at a time. Next slide, please. So what we've learned so far in final summary, the results haven't come easily. The learning has been as much as about how we've worked, not just the what we've delivered and the impact. And some of our clearest lessons are that shared ownership doesn't emerge organically. This isn't something that you just hope will happen and then wait to see if it does. We have to design it into the things that we do, but it goes beyond the governance and decision making. It's a system where we've really got to change the culture, and we started doing that. We've learned that missions lose power if they're treated as a subset of people who will go on and do it on behalf of everyone. It only really works when a whole bunch of organisations and people see themselves as collectively accountable for that progress. Clearly, work needs to happen in smaller groups and smaller factions, but across the missions, people feeling like they're accountable across organisations has been really important. And we've had an R&I, Research and Innovation Board, to hold that accountability for the system. And we've also learned that scale doesn't happen by accident. If you don't plan early on about how you're going to adopt, scale, sustain and spread and think about funding, then these things really don't meet the potential that they have. And finally, data has been a really important part of what we've done, as well as governance. They are abilities to enable learning, accountability, demonstrable impact, benefits realization, and give us confidence that we're on the right track. And we've been spending a lot of time thinking about our logic models and leading and lagging indicators that give us that confidence. So finally, quickly, I'll rattle through what does this mean for systems and leaders. Particularly, this is a leadership challenge. Mission-led innovation isn't a quick fix and shouldn't be approached as one. So if you were on this call thinking, how do I quickly enact missions into my work and start doing that fast? I'm afraid we need to burst the bubble and say this isn't a quick fix, but you can learn from the things that we're doing and others and hopefully expedite that journey. And it does offer a credible alternative to a whole bunch of pilots and short-term programs that have often been in play. And that allows you to crowd in a lot more resource, signal to the system and to partners and investors and others about the things that you're trying to do, and help pile in and leverage more into a smaller number of priority areas. And for leaders, the implications are really significant, and it's about understanding what really matters in a system and doing that work up front to say these are the things we're going to focus on. And it does require this visible, sustainable leadership, particularly when organisational pressures pull us in different directions. I've mentioned being comfortable with managing risk and iterating, failing and learning. And finally, these things only really become real when a lot of things align. And we've been working really hard to try and do that around the funding, as I say, around taking a system governance route that's different to organisational governance, and trying to think about that alignment to really enable this to be conditions that help things flourish. But these are not easy choices for leaders to make or be part of. And even if you're not the person designing or leading at a system level, you are somebody that is championing or delivering the work. Being bold and pushing up to the leadership to say, look, these things need to be in place for this to flourish and really have impact is a really important role. So let's pop to the next slide. Really keen that we open up to questions and sharing your insights and comments in the chat. And I think we're going to take the slides down now and share some insights in the chat, and I will sort of farm that out to various different people. So thank you for those who have taken the time to do that. So Matthew, there was one that came in earlier on, I think from Poonam, which was a great one, which was about is there a playbook about working with industry? I guess that speaks to some of the wider role that HINs have at that intersection with industry, but I guess also your opportunity to bring in some reflections on who we chose to partner with more at a strategic level, and also how we've been working with innovators and help to sort of choose and support them at a more local level for some of the interventions we've chosen. So Matthew, why don't you come in on that one?
Great. And I think this is one of the real fundamental bits of missions. It's because there's this often repeated saying, like, good strategy is knowing what to say no to. And I think by having the missions, we've been able to be far clearer about what partnerships we want to prioritize and not. And that has dividends for lots of different reasons. So for the big partnerships which we have worked with, so companies like PopDoc and so on and so forth, it has allowed us to be very clear, like, this is what we want to prioritize. If you have products or services in this space, please come and partner with us to work with this. And I think also counterintuitively in our role in terms of supporting SMEs, it's allowed us to say no to other sectors as well, because going around speaking to NHS partners can be a big times burden on smaller companies, and therefore us being able to have a quick no has also enabled them to be able to focus on and crack on and not waste their time. Very practically, when you get into working with industry, I think it's very important with all missions and for all of us, right? We've got to build on what has come before us. So actually, we've heavily leaned into ABPI and NHS Confed guidance in terms of working with industry partners. I would, if you haven't seen that guidance, I put it in the chat, I would suggest that you do look at it. I would say some of the principles in here are generalizable to beyond the pharmaceutical industry. So that has helped inform how we have engaged some of the challenge within that. What I would say is, beyond the guidance and a bit more real practical things, is at the core of missions is trying to find the mutual win-wins for this, and being frank and upfront about what it is that individual partners are hoping to get out of the partnership, and not shying away from those different incentives and reasons for being it is very, very important. So the more you can be open and honest about what you're hoping to achieve, what someone else is hoping to achieve, and what different partners can contribute, the further and faster any effective partnership will go.
Brilliant. Thanks, Matthew. And there was a mention of toolkits. I know we've got some bits on mission toolkits. We've got lots of other toolkits that ICHP and others produce. Is there places we can signpost people for toolkits? I suppose we can probably put some links in the chat as well, can't we?
Yeah, absolutely. And look, part of what we publish in the mission report is our thinking within that. Internally, the team are working on our own toolkit for V2, and there may be a future where we start to share some of that in a more open space. I'm also happy to share a healthcare transformation toolkit on Trello, which we've had previously. So I'll put that in the chat shortly, which has some of the tools and techniques for different bits of healthcare transformation.
Brilliant. This chat is turning into the most valuable part of everyone's day, I think, hopefully. Right, Laura Boyd. Hello, Laura. Thanks for your great question. I'm going to direct this one to Charlotte, I think. So you have asked to say a bit more about the partners around the missions, and really importantly, outside the NHS, 100%. This is about sort of outside of just the traditional organisations that come together to solve these problems. So how we've engaged with academia and VCSE, and how do we maintain the focus in missions. So Charlotte, we've done that a lot in our children, young people's mental health mission, haven't we? You can say a bit more, I guess, about the Driver project that has been with academic colleagues, and we're doing things in schools and working with VCS and others. We've had our innovation forums that have included that. Charlotte, why don't you come in on the sort of wider partnership point on that?
Thanks very much. And so I think, the focus being NHS organisations, and aware that we can't sort the problems out by ourselves, also aware that in terms of co-design with wider system partners, that's exactly what's needed to ensure that what we're doing actually there's a desire for, so that when innovation and the ideas that are coming along are not felt that they're top down, but actually they're then being pulled through and they're being wanted by people who are working on the ground and people who residents or patients on the grounds as well. So in terms of establishing, so where we've got definition of what the problem is and where we've got system buy-in to actually what the problem is across the system, then working with our health innovation partners, so the fantastic ICHP that I've been used to working with, in terms of looking to see what's out there. And as Matthew's just mentioned, actually a lot of that's about, in terms individual organisations can be completely flooded by actually requests from some relevant and some less relevant innovations out there. So actually doing that scanning and seeing what's out there, what's the art of the possible, once we've actually defined exactly what that problem is. And sometimes the problem that we have is sometimes in advance of where the solutions are. So one of the examples of what we're looking at from the mission 3, so that's the mission we're saying that we've set out, we referenced it in the beginning. So the aim is to reduce by 25% children and young people who present in crisis into ED. So, and a huge issue that we've got. So actually one of the iterations of the mission has been to see actually how do we better manage the pathway in through the assessment for neurodivergence. And what we're looking for, doesn't actually exist at the moment. So we're working with, and we're doing a procurement, looking at what there is out there and what we can actually end up working with at the moment. But sometimes the problem that we haven't quite got the solution out there, and then that's also the role of the HIN to actually see and help stimulate. So it's a two-way conversation. It's not just one way of being shown different potential innovations. It's helping to shape the market that sits out there. One of the VCSE embedding work into communities, I would say particularly with the work from the first mission that we've got, so the problem of cardiovascular challenge, where we've got lots of people who are not diagnosed, not detected, who've got high blood pressure, high lipids, actually working with VCSE to actually ensure how we're looking to innovate, help us be on panels, help us look to see actually when we're looking to choose what the potential innovation partner is going to be, that it actually works for them. So really key features in the whole process from start to finish in embedding innovation. Thanks.
Thanks, Charlotte. Laura, I hope that answers your question. Adam, there's been a few questions in the chat for you, which you've done a brilliant job of answering. I guess I want to pick up the important question of funding. And we've been thinking about this in a number of different ways. The missions have enabled us to leverage strategic partnerships with commercial organisations, industry, pharma and others for some of our missions. We've also been able to draw in grant funding, but there is something about how do we sustain both set up and then sustain these models through BAU. And you've been asked a question specifically about the Optica funding, but do you want to come in on that? Definitely, we've got lots of work that we need to continue to do around funding, but why don't you come in on funding?
Yeah, I mean, just to reiterate, I think it's a significant challenge there, isn't it? And making sure that we've got the innovations that we're trying to work on are well aligned to the funding streams. And I think that means alignment to ICB planning cycles and a good understanding of certainly of the grant and additional funding opportunities that exist in the environment. I think with the Optica example, we were we were in the fortunate position that in terms of the actual funding of the innovation, that was already funded via NHSE on the federated data platform as a product. So we knew we had the product there in the first place. However, there's still additional funding that was required through that, not least the sort of how do we fund the ICHP team that was supporting this, and that was obviously through our model as a health innovation network, and how we were supporting missions across the system. We still needed to release capacity in with partner organisations to be able to spend the time and looking at the transformation, which isn't always easy when people are at the coalface and have incredibly intense environments that they're working with. And then further, when we looked at the scale, I mentioned in the chat that the ICB had certainly a commitment to want to scale this. Then appointed a consultancy partner to accelerate some of this scale as well before it going into BAU. So there are a number of places, even when we had the innovation itself funded via NHSE, that we'd need to think about being able to find the right resources to be able to achieve scale, which I think is a significant challenge.
Brilliant. Thank you very much. Laura, I just wanted to come back to your question. I realised there was another part about how do we sustain energy and momentum, and Charlotte and other colleagues have lived this through going through consultation whilst trying to keep this show on the road with missions. And I'm sure Charlotte will agree. We know it's really hard out there at the moment. There's lots of challenges. I guess what some of the things that I've reflected on personally is, if you make the forums by which you are working together on these things and doing some of the accountability both impactful but also I guess meaningful, and where possible fun, it does keep people turning up and keep committed to the work. And we heard time and time again people saying, this is the best bit of my working week, this is the bit of the meetings or the work that I enjoy the most. And so I think where we can make this stuff really meaningful, it does keep people coming back despite of all the busyness and the big distractions that are going on around the system. So we continue to keep iterating that, but it's a good prompt to think about when your numbers start to wane in meetings, and we did check those, and that was a metric. What are we doing wrong, or what do we need to be doing to change it to get people coming back to keep participating? So that was a really important part. I'm having a look at the questions. Stuart has asked a great question. While different stakeholders might sign up to the broad agenda, there'll be difference in interest and immediate priorities in different teams, which is, of course, classically one of the tensions around missions. So how do we manage that? Matthew, why don't you come in with a few thoughts on what we did early on around trying to get to a problem statement or set of priorities that did mean enough to everyone, but bring in that difference and tension through the mission work?
Yeah, look, and this is where this still happens, right? So without naming any individual organizations, in mission 3, as Charlotte looked through, so Children and Young People's Mental Health Mission, we are in a live procurement where we will hopefully be building something which we believe is of value both locally and nationally. But there are some organizations that do not want to be part of the first wave. And I think, therefore, for me, the answer to this is, how do we maintain the goal of scaling in mind and involve colleagues on that process for both key design features and also enabling that kind of, and sorry to use jargon here, fast follower afterwards. So a very tactical kind of thing which we have done is we have made sure that any organizations that weren't sure about being part of the subsequent waves, we have included them as part of this procurement decision, and so on and so forth. So we're maintaining that engagement and momentum throughout, so that should, after this initial test, what we have built become viable for them, we're not starting from scratch in terms of that engagement. So there is something about how you keep the mission collaboration and the innovation network alive, even if there may be different levels of intensity and enjoyment within that. And then I think the other bit which we've not done as well on is missions as really massive collaborative endeavors, because actually this isn't about ICHP and the ICB saying these are the mission projects that we're going to be doing. but actually it's about trying to get the system to galvanize around these. And there may be some projects that we're just aware of or initiatives that are contributing to this all. So hopefully by setting that systemic goal, you can still allow individual organization actors to work on things that are important to them and connect in, even if, and that may be stuff which is competing. And actually, when you go to like depths of mission theory, it's actually good to have these competitive tests, because actually if one organization does something really well, other people can learn from it. So it's really important that you have the learning infrastructure to enable those multiple tests to come together for the benefit of the overall mission goal. But we have not gotten there yet, but maybe Adam can do that in the next mission.
Brilliant, thank you. I should mention there are lots of lovely ICHP team on the call who are trying to pick up questions in the chat. We've had a brilliant one about when you say no to innovators, he's still signposting them to the HIN universal offers. Absolutely, and Lucy's popped some bits in. Claire's offered to pick up questions around partnership working beyond the usual sort of health partners. So plenty of people on the chat. I've also put the more generic ICHP email inbox into the chat as well. If you've got any problems accessing that Trello, which we will try and sort out, or any wider questions that have come up today that we haven't managed to answer, we would be happy to pick up. But there's plenty on LinkedIn about our report. There are lots of people named in the report who've been part of or close to the work, so feel free to get in touch or reach out to them. But really a collaborative system team event and today, and very much the work is a big sector-wide, I guess, leadership role that we've all played as one team across North West London. So I hope that that has given what is undoubtedly only a scratch to the surface of some of the things that we've been doing as our mission-based approach. Please do take a look at the report. It's got lots of rich learning in it. We are still early in our journey. We're really looking forward to hearing how others are getting on who are doing similar work. So if you're taking a similar approach and you're further ahead or a bit further behind and want to share or learn, we'd love to hear from you as well. We've also reflected in the report from other health systems where we've learnt a lot from, and people have been very generous in the chat, posting fantastic resources to work they're doing. I can see some things from the innovation unit. Many other people have been offering and sharing to get in touch, and this is what this work is all about, really creating communities of people who are doing this work that's really exciting, interesting, challenging, and requires us all to sort of learn and share and support each other. Now, my job is to just close us off and get us all away on time. So I just want to say thanks so much for joining. I know that you're all very busy, and at our peak, I think we had at least 110 people online, which was fantastic to see so many of you. And it's great. Thank you so much to the panelists. Great to have your reflections with us and sharing. But as I say, a real team effort, many people online and others who aren't, to say thank you to. As I come to a close, I just want to return to that comment that I sort of opened with. Across health and care, we're not short of ideas, pilots or innovation, but we are short of ways to consistently turn that into a sustained system challenge. And so how are we doing that? Hopefully what we've shared today is not the perfect or only model, but it is one that gives you a sense of some of the things that can be achieved when you really put collective action behind a set of priorities that people care really deeply about. We want the report that we've launched to offer those reflections and insights and be a learning asset, not necessarily a verdict on how to do everything. So please do read the report with a bit of a leadership lens, whatever your place in the system. Hopefully there's something in there for you, and do connect with each other. As I said, it's great that people are already connecting in the chat, but keep in touch with us. I want to thank Matthew, Charlotte and Adam, Emma and colleagues at ICHP, Jack and Hannah, who helped to pull the report together, and in particular the Health Innovation Network for giving us the chance to platform and spotlight our work, of which many other HINs are doing fantastic work in similar spaces. And mostly thank you to all the colleagues and partners across North West London who've brought this approach to life, and thank you very much for joining. The recording will be shared by the HIN team shortly, so if you want to find it, share it with colleagues. It will be circulated, or at least the opportunity to find out where it is. And if you haven't received your copy of the report, we'd urge you to have a look at it. We've popped it in the chat, and hopefully you will enjoy and delving into bits and pieces as you progress with your work. So I've managed to wrap us up a minute or two early. I'll just check in the chat to see if there was anything else. Some nice comments with lots of people saying thank you. And I wish I'd known where people were from. I should have said, where have you called in from or dialed in from? We've got people listening in from Denmark, which is fantastic. People looking to export to Spain, and a truly global and international flavour. So thank you. Let's keep in touch, and brilliant to have you all online. Thanks so much for joining. See you all again.
Thank you.